presentation. I'm going to try and be as specific as possible. There's, of course, dealing with anemia, but there's also you can do in terms of therapeutics.
Un peu complémentaire.
She got interested in alternative therapeutics, and especially in ginseng. That is extremely interesting, and she paid attention to its physical properties. You have a presentation on, a questionnaire on sports activities. Please have a look at this questionnaire and answer it. So the problem of fatigue, it is pain that is major, that might impact diagnosis. It happens sometimes before cancer is diagnosed, and it can go on after cancer is treated. For instance, in breast cancer, we know that fatigue can go on for 34% of patients for a year, 5 years, or even 10 years after the treatment ended. So you see in this slide, fatigue can exist before and after treatment, which is why several recommendations were published by American companies. The NCCI, for instance, published this table and benchmark for dealing with fatigue. We have also the Oncology Institute that offers guidelines in caring for patients, and also the APSOS reference or benchmark is available, and it's available on its website. So the guidelines go beyond these scientific societies' guidelines. You see still the importance of physical activity, but also behavioral aspects, supporting patients from a cognitive point of view, and you have also the Canadian Society with different levels depending on the level of physical activity. What should be offered when you have a complaint about fatigue? First, you have to identify the reason, and from a pharmacological point of view, you have to identify whether some treatments cause this, or interaction between treatments, some as psychotropic treatments, but you also have to look for pathologies that might trigger fatigue, denutrition, hypothyroidism, anemia, or other comorbidities. Psychostimulants were tested each year when attending the ASCO convention. It's changed in the last year, but we had topics on dealing with fatigue using psychostimulants. And their usefulness in the case of severe fatigue was mentioned, but it wasn't demonstrated in the various studies published regularly. Steroids now, as usual. I mean, this morning we spoke of corticoids. It is the molecule that used to be considered to be the miracle molecule. It remains a miracle molecule, but certainly from a physiopathological treatment, is the one that explains its action most clearly with different cycles that enable the patient to go over some difficult stages. And we've seen that the doses are relatively significant. And what is known in terms of physiology, it is an inflammation mechanism. The cancer is an inflammatory mechanism, so it's going to trigger inflammatory anemia. So we shouldn't stop at ferritinemia. But in this context of inflammation, cytokines are going to be released. And in this inflammatory setting, probably there's going to be hypothalamic pituitary adrenal this system might be also inflamed. So, what about psychostimulants? Deborah Barton says that their interest is not demonstrated. Steroids, on the contrary, have an anti-inflammatory activity. And when we see their impact on fatigue, we can very well imagine that they have this action, and that's what we're using on a daily basis in palliative care. Ginseng, so it's a small molecule. The American ginseng is the one that's suggested here by Deborah Barton, and we have the one used in traditional Chinese medicine, and the American one, I can never pronounce its name, says the speaker. Both were presented in various publications and in various conventions, and they both have some interest, but here we're going to pay attention, well, Deborah is paying attention to American ginseng. Why use ginseng? Ginseng could have an anti-inflammatory activity. Its action onto cytokines would enable for an anti-inflammatory process to be induced, and an increase in the endurance level that was actually seen in studying this on mice. So the randomized study presented by Deborah Barton, we have 2 grams per day versus placebo twice a day for 8 weeks, with the idea to actually show the benefit of ginseng. Now, in terms of patients, they were adults with cancer with a severe level of fatigue that's above grade 4, a curative intent, and they had other causes of fatigue ruled out, such as thyroid, anemia, pain, or insomnia. Now, in terms of primary endpoints, this assessment is done according to the MFSE scale, and other scales were suggested for the general condition, with a digital scale rated between 0 and 4, with 0 not at all and 4 extremely. And then the side effects, we're trying to assess the side effects, the negative events linked to ginseng. But there's still a question that remains as to its impact onto the cancer itself and carcinogenesis. So there were 2 stages for assessment, 4 weeks and 8 weeks, with the patients, 150 patients per arm. And the assessment was done depending on the level of fatigue and the treatment of the tumor. So you see 364 patients enrolled in this trial, 1 arm with ginseng, 1 arm with placebo. They were quite comparable, and when we take the characteristics of the patients globally, we have the same balance between the 2 arms, with a little more women in the arm with ginseng, and this is due to a little more patients having breast cancer. So now, in terms of the features of the treatment, so we had a treatment time over 40 days. We had patients that were undergoing hormone therapy for a non-negligible size of them. So after 4 weeks, no significant impact, no difference between the two arms, ginseng versus placebo, but after 8 weeks, we see a significant change for the MFSI scale with 0.03 after the coma, which shows a delayed impact of ginseng onto patients. If we if we get into the details of the MFSI scale, we see efficiency as to the physical component. Now, as for the global outcome, we didn't see demonstrated efficiency for the emotional, the mood part of this fatigue phenomenon. Now, the other objectives, we have positive outcomes after 8 weeks as to this inertia issue, this fatigue. No results after 4 weeks, but good outcomes after 8 weeks. And if we look at the other subgroups, that's patients undergoing cancer treatment or patients not under treatment, you see that it's more positive for patients undergoing cancer treatment. But there's no such modification for the patients who are after anti-cancer treatments. So this means that the agent stimulating erythropoiesis shows that ginseng would have efficiency during the treatment, but no interest if you're away from the anti-cancer treatment. Now, if we have a look at side effects, no significant side effects. So the conclusion of Deborah Barton is that Wisconsin ginseng has an impact onto fatigue linked to cancer, especially when they are still undergoing treatment, and toxicity is quite moderated. We see great improvement in improving the physical side of fatigue, but no improvement as to the other elements, such as cognitive or mood-linked. Now, physical activity, she had a global overview of this. Physical activity is part of the recommendations made to the patient. The first question is, how do you suggest this to the patient? It has to be adapted and not have physical activity at any cost, which could trigger other damages. And Dr. Crawford is working a lot on sarcopenia, and there's here a risk to increase severity of sarcopenia if things are not properly weighed out. So here it's quite interesting, because the idea is as to whether we tell the patient to go for physical activity or we try to support them in doing this. So we have here a randomization with a usual management of the patient, just saying that you need physical activity. A second one recommending with the exercise package. We have patients that had early stages of cancer and colorectal cancers. And when we have a look at this trial, we see that when we offer a full package, that is real support in doing physical activities, we have a benefit that's extremely positive. When we have patients to whom only the recommendation is made, well, we have no change. And when we have the usual care control, we see that they go for even less physical activity between the beginning and the end of the follow-up process. Our role is to support the patient, to introduce to them the baseline, to explain to them, but also to offer something rather than just say, do this, do that. You should. So the physical activity prescription, well, the patient should have regularly physical activity, not once a month, every 3 months, or once a year, as Vincent used to say. He's not here yet, but every time he laughs about physical activity, because of course he does it himself only once a year, but this physical activity has to be motivated. We have to have real presence by the side of the patient. We have to have real support and make sure that this takes place several times a week with at least half an hour each time. And at the same time, the support is going to be really beneficial here. Now, there's also psychosocial support, psychoeducational. That's another side of the support to our patients. This is another study with results that don't show many benefits. So we have here on the one side a study that says that it's useful, another one that says it's not that useful, which is why some don't recommend it. In the context of this study published in 2004, we had almost 400 patients who had this support, with the patient getting phone calls, an assessment of the patient's fatigue according to several scales, and it seemed that there was less fatigue with the patients who were getting this follow-up, this support. So that's in favor of the behavioral aspect. Now, we have this study dealing with cognitive behavioral support. The results are not really positive, which is why in the recommendations we have several suggestions for or against these suggestions. Now, to conclude, I hope that I introduced to you as clearly as possible the findings of Deborah Barton. We lack knowledge. All we know is that we're dealing with an inflammatory phenomenon. So we have to deal with this aspect, which is why treatments are taking this therapeutic pathway. Deborah's identification of ginseng action is very interesting from that point of view. But it has to be discussed with the patient. He has to be supported. I mean, he needs to be offered a behavioral approach. And the American ginseng, as Deborah is American, seems to be a reasonable solution. And in all that was published recently in therapeutic terms, it's the only thing that really shows interest besides corticoids. And this is a photography of the Eiffel Tower, which wasn't blue, white, red at the time. Well, I suggest we discuss this around a glass or around a lunch tray, if you have questions on ginseng, that is. Yes, simply, you showed that there was an anti-inflammatory effect, an inhibitor for MAP kinase pathways. So maybe it shows some anti-cancerous effect. And second thing, in terms of treatment, we are warned more and more often against interactions, cytochromes, and so on. Do you think it's 100% safe? Yes, it was mentioned as anti-cancerous. Well, I think as an molecule against the cancer, I think we shouldn't take this direction, but it is not pro-cancer anyway. But we have to carry out other studies to confirm therapeutic efficiency when other molecules are interacting. I think no interaction has been proven yet. So this is a question that crops up again and again, of course, in such publications. Mario?
Vous n'êtes pas sympa. Vous n'avez pas posé de questions à Yvan sur la présentation de l'opinion.
You're not nice. You didn't ask questions to Yvonne after his presentation. Now you're going to overwhelm me with questions. For the chronic inflammatory syndromes, such as Crohn or other, in oncology, what you know, does it show that people who have persisting fatigue symptoms after their treatment be finished, for instance, so when you have breast cancer treatment, do you see such a phenomenon? No, I'm speaking of fatigue in general. Well, I don't have such an answer to this. I imagine that because it is inflammatory, it's the same thing. People complain from the same level of fatigue. The second question, what was it about? A patient who recovered from cancer. Do we see some mechanisms with cytokines, for instance? So chronic anemia doesn't exist only in cancer, in chronic diseases. For instance, in the Crohn disease, we have seen some progress and correction for anemia with TNF-alpha. We see that anemia is corrected, so we can ask the question for fatigue as well. I agree with you. Do you have other questions? Do you have data on Qigong? Validated, mentioned data. Well, we have data validated. I can't say so. I mean, many data seem to show a positive impact. Do we use it in our daily practice? Yes. Do we see some benefits to our patients? The answer is yes. From a scientific point of view, this is part of alternative practices with a therapeutic target. It is part of the alternative medicines in the United States with randomized studies comparing. But do we have a positive outcome when dealing, for instance, sometimes with patients who do have an anger for this and others who don't? I mean, we dealt with this with AFSOS, and you can have a look at the benchmark of AFSOS, which are on our website, www.afsos.org. We've put into place some alternative practice. We have a nurse that does Qigong, and the patients are quite satisfied. But the patients who turn to this therapy are patients who globally have the idea that this is going to add something to their condition that's going to improve it. But it's, of course, it can be also in support of physical activity, and it gives benefits, that's for sure.